Okay, orbital cellulitis and sinusitis. It's a very important guideline. The infection chapter in the pediatric guideline. Okay, recognition and assessment. Orbital cellulitis is an ophthalmic emergency that can cause slight financing or life-threatening complication. Orbital cellulitis symptoms. It comes with fever, level of consciousness, headache, history of sinusitis, upper respiratory tract infection, dental infection, eye problems, sty, lesion, dacryocystitis, trauma, or recent surgery. Vaccinations, especially the Hib vaccine, comorbidities, for example, immunocompromised or diabetic. So again, orbital cellulitis, it's considered to be ophthalmic emergency. And its life-threatening complication may end up with blindness, fever, level of consciousness, headache, history of sinusitis, upper respiratory tract infection, dental infection, eye problems such as sty, lesion, dacryocystitis, trauma or recent surgery, vaccination, especially Hib vaccine, comorbidities, for example, immunocompromised patients or diabetic patients. This table is showing how to distinguish between the orbital and preseptal cellulitis. So we have two types, orbital cellulitis and preseptal cellulitis. So what are the differences in here? Let's take it one by one. So preseptal eye can be examined. In the orbital, unable to examine the eye. In preseptal, facial erythema and tenderness. In orbital, painful eye movement or ophthalmoplegia. In preseptal, normal eye movement, while in orbital, there is orbital pain and tenderness. Normal vision in preseptal, visual impairment in orbital. Sometimes you'll find red, green, color differentiation lost early as well. In preseptal, preceding superficial trauma. So there is a history of trauma in preseptal. Sometimes in orbital, there is preceding history of sinusitis. There is eye pain in preseptal. In orbital, there is apoptosis, chemosis, pupil or fundi abnormality as well. So apoptosis, chemosis, pupil and fundi affected as well. In preseptal, we have periorbital swelling. In orbital, we have decreased Glasgow coma scale and headaches. So even the Glasgow coma scale will be affected in orbital. In preseptal, there is a fever. In orbital, the baby or child will be systemically unwell, toxic child. So again, the differentiation between preseptal and orbital in this table is very important to know how to differentiate between both of them. Okay, including relative different pupillary defect. Okay, that's the star of the pupil. What does it mean? It's affection of a pupil in orbital cellulitis means pupillary affection in many ways. Okay, maybe visual field defect, accommodation, light reflex as well may be affected. Okay, if uncertain, manage as orbital cellulitis, pending CT and ophthalmologist review. If you are not sure whether this is preseptal or orbital cellulitis, so you have to manage it as an orbital cellulitis. You have to postpone the CT scan, and ophthalmological review should be pended. Okay, investigations. So what we should do in blood test. First of all, eye swab, send bus if present, full blood count, blood culture, CT scan if orbital involvement suspected, central neurological signs, unable to assess eye movement, vision, or if eyelid cannot be opened, bilateral edema, deterioration despite treatment. So all those are indications for CT scan in orbital cellulitis, or if you are suspecting orbital cellulitis. So eye swab for blood count, blood culture, CT scan, if there is orbital involvement, very clear, obvious. If there is any CNS involvement, unable to assess eye movement or vision, the child cannot open his eyelids. There is a bilateral, obvious bilateral edema and deterioration despite starting treatment. MRI if neurological signs or suspicion, evidence of intracranial involvement on CT scan. So if you have done a CT scan and you have found something weird, or there's an intracranial involvement, for example, cervical sinus thrombosis, stuff like that. So you will go ahead for doing MRI. Okay, management. We have the pre-septal periorbital cellulitis and orbital cellulitis. So the management of pre-septal periorbital cellulitis, if limited to upper eyelid. So if we have only the upper eyelid involvement, so that's oral co-amoxiclav. Review eye movement and red green color vision twice daily. If both eyelids severe or no improvement after 48 hours, give IV co-amoxiclav. So first of all, if the swelling is limited to the upper eyelid, we will start with oral co-amoxiclav. On top of that, we will review the eye movement, the red and green color vision as well, twice a day. If both eyelids involved or severe enough to involving the both eyelids, and there's no improvement within 48 hours of starting commencing antibiotic. So at the moment, he will need IV co-amoxiclav. If improving, convert to oral high-dose co-amoxiclav. If penicillin allergy, we switch to clindamycin. Total duration of treatment, including the IV, it's 14 days. So for pre-septal cellulitis, the whole duration of treatment is going to be 14 days. If penicillin allergy, switch to clindamycin. If improving, if showing signs of improvement, we switch to oral high-dose co-amoxiclav. If only one eyelid involved, oral co-amoxiclav. If both eyelids involved with impaired visual eye movement, red or green color affection, indeed we will switch on IV co-amoxiclav. Okay, let's go to orbital cellulitis. For orbital cellulitis, urgent ophthalmology ENT review within 4 hours for assessment for surgical drainage. So orbital cellulitis is an emergency indeed, and we need to consult the ophthalmologist immediately. ENT review as well within the first 4 hours. Within the first 4 hours for assessment for surgical drainage. We commence IV ceftriaxone, which is Rosifin, I guess. IV ceftriaxone, 100 milligram per kg, maximum 2 grams, or cefotaxime, 50 milligram per kg, maximum 3 grams, if ceftriaxone contraindicated. So in orbital cellulitis, we will start with, after consulting the ophthalmology and ENT review, in the first 4 hours, we have to start the IV ceftriaxone immediately, or cefotaxime, IV ceftriaxone or IV cefotaxime. If toxemic, add clindamycin. If the child looks very toxic, we add on top for IV ceftriaxone or IV cefotaxime, we add on top clindamycin. If history of anaphylaxis to penicillin, give ciprofloxacin and clindamycin. So if there's any history of anaphylaxis to penicillin, so we have to give ciproflox and clindamycin, If improving, convert to oral high dose coamoxiclav and penicillin allergy, give clindamycin. Total duration of treatment of orbital cellulitis is going to be 21 days up to 6 weeks if bone involvement. So at the orbital cellulitis, the whole duration of treatment is going to be 21 days, extended to 6 weeks if there's bone involvement, the orbital bone involved. So you will need to continue treatment for 6 weeks. Preseptal cellulitis duration of treatment is 14 days. Okay, let's move to the next page. Okay, if we have intracerebral complication, so if you found any serious involvement, that's mean that there's intracranial complications in place. So urgent neurosurgical review. So you have to consult the neurosurgeon in pediatric to have a look on the child. Sinusitis, upper respiratory tract infection symptoms, 10 days or more, and 1 or more of nasal congestion and discharge, persistent cough, often nocturnal. If acute, treat with amoxicillin. Change to coamoxiclav if no response after 48 hours. IV if severe, total 7 days antibiotic. Sinusitis considered to be severe if there's a falling in Glasgow Coma scale, temperature more than 39 centigrade, virulent discharge from the nose, ENT neurosurgical review. If complications are present, orbital CT with contrast, neurological MRI with contrast, plain CT of sinuses for sinusitis. If stable, can be done as outpatient. So this is the guideline of the orbital cellulitis and sinusitis. Thank you for watching. Bye-bye.